experts in clinical nutrition from KNH, whereby he's recognized as a leading voice in the interactive health. That is Gereso. And he specializes in the functional therapeutic nutrition. His unique combination of the holistic and clinical experience ties an alternative approach to modern nutrition coaching. And he holds a bachelor degree in human nutrition and dietetics, and is also a bona fide member of the professional body, that is the Kenya Nutritionist and Dietitian Institute. With more than 10 years experience, the diverse experience in the field of clinical and holistic nutrition, along with clinical internships and research, he has worked with a wide variety of clientele and focusing on the endocrine health, nutrition and performance, supplementation and dietary behavior modification, together with mind-body wellness. He's one who is driven to help his clients to better understand the complexities of their bodies and health, and has spent greater part of his career exploring the impact of diet on the overall health and helping his clients correct the nutritional imbalances. And with that, probably we can give the floor to Kihugo Ngereso to give us now the presentation on medical nutrition therapy in cancer. Welcome, Kihugo.
Good afternoon, members. Hello, good afternoon. Good afternoon, participants.
Yes, good afternoon.
Thank you very much, Mokua, for the brief introduction. Well, I'll be taking you through this session on medical nutrition therapy for cancer prevention, treatment, and recovery. And as been said, my name is Kihugo Ngereso, and I work at KNH in the nutrition department. So straight to the task at hand, our objective by the end of the session, I would expect that the participants will be able to understand the causes of cancer, appreciate the role of nutrition in the prevention and care of cancer, and also appreciate the role of multidisciplinary team in cancer care as we go by. Now, straight to the causes, I've introduced a seemingly unique cause labeled sin, which across the board, I haven't come across something to that direction, but it's of interest which we cannot ignore. Because biblically, of course, tumors have been documented, but of course, that also is related to if people do contrary to the will of God. Because questions of interest at hand should be concerning human evil. Then what we need to address or rather answer is, where do they come from? And therefore, how do we solve it? Because it could be out of the wrath of God that also become victims of the burden at hand under this consideration. So genetics is also identified as a real-time cause. But of course, now, this is well researched on in academia, so that if a person has a history in the family of the burden, then likely chance of being exposed is real. Immune factors, and then there is also environmental factors, so based on industry or environment where we work in. Physical activity, so this has to do with the balance of energy in terms of energy intake and expenditure, which will actually, if the intake outweighs the expenditure in terms of not being physically active, then overweight and obesity becomes a real-time factor in the occurrence or in the prevalence or the onset of several forms of cancers, which have been well documented on. Now, in the discussion, mainly we'll be looking at dietary factors where now nutrition is the subject, and we explore on how does diet facilitate in the initiation of cancer, and also how does diet facilitate in the promotion of cancer, and how does diet in the treatment or the protective factors which diet provides towards the problem. So the diagram outlined basically is, I would call it a conceptual framework that shows an interplay of factors which have been documented in the initiation promotion, and progression of malignancies or cancers. So chemicals, that has to do with the environment, which we talked about earlier. Excess energy, macronutrients, especially unsaturated fats. So in this case, has to do with what you're talking about, physical inactivity, and therefore, if obesity and overweight becomes the threat, then obviously it also can have a role real time. Viruses have been identified also independently, like say the HPV. And then we have radiations. So this is about the environment where we are working in, the chemical exposures and related, causative links. Limited antioxidants and nutrients and non-nutrients. So on the on that aspect of limited antioxidants, basically it also has to do with how are our eating habits. So that now, if for instance we know vegetables and fruits have got those antioxidants which are also confer protective benefits to individuals. So if the intake is limited, therefore the benefits arising out of such food commodities, then we lose them, and therefore predisposing our bodies to environments that will actually promote initiation, promotion, and progression, and therefore the malignancies being real time. So in this case, I've single-handedly put seen independently because it's one thing that has not been of discussion in the healthcare environment as a red button also, so that we of course, we cannot single-handedly isolate science and religion. And therefore, striking a balance between these two will actually see us progressively forge ahead in addressing the concerns around us. Now, the photo displayed is actually linked to the discussion currently in the national environment concerning, like say, the subject around GMOs, because there are markets, especially now in the European environment, where now consumer education has come to the level whereby you can buy, you visit the organization like say foodnews.org, you can buy based on your profiling of the particular commodities or of whichever market you want to buy. Locally, for instance, every Sunday, I suppose, even in Kilimani area, there is usually now an organic farming market. So eventually now, the future we are heading into is a situation whereby the market will be segregated based on as to whether you are health conscious and therefore you go buy what, based on the profiling of the commodities, you are convinced that now they'll address your health interest, or based on what you buy, or rather what you can afford. So you only buy for as long as you've consumed or eaten something. So the question in Kiswahili therefore would be, is it chakula bora ama bora chakula? That's actually what the diagram is trying to illustrate. For instance, if you have to look at now, say the diagram having the apple, where now it has been labeled 30 dozen. So number 1 to 3, worst based on now the agro processing mechanisms involved in the production. And therefore, they become more or less like high risk in terms of predisposing one to the chemicals of interest, as explained earlier in the chemical causes based on production. On the right hand, where we have got the clean 15, lowest in pesticides. So you can see 1, 2, 3, they are described to be as best. But you see now, of course, in this case, if you were to look at onions independently, their production may require minimal use of pesticides naturally, because they have got minimal threats to their survival. The same also even may apply to pineapples. Usually they have minimal attacks environmental wise. They have less threats as you are to compare to, like say, apples, celery, and the rest of such. So in this regard, this prompts us as healthcare workers, therefore, to participate in the national conversation around what do we want? Is it using fire to put off fire, as in addressing hunger with the mechanisms that also could be a threat long-term to the health sector, or what available better options should be in place to see us move together whether with the minimal concerns or consequences? Because remember, we talk about cancer, it's not about the number of patients or the patients at hand literally. It's also about the number of patients or the succumbing to the problem in the future, in which also we are the people who will be in that future. So our time is now to give informed opinions on the subject, so that now consumers are, are reassured of whatever is going to be on their table is not just for the stomach's sake, but rather for their quality of life long term. So epidemiologic research has evaluated the role of diet in the etiology of cancer in different population groups. So, and the conclusion of interest is diets contain inhibitors and enhancers of carcinogenesis, as earlier discussed. So from laboratory studies with several animal models, you find that effect of food and nutrition on cancer development has been researched on. And that's why the only caveat on doing the researches on humans is because of the ethical involvements, the ethics involved, and therefore limiting extrapolation of the findings from the laboratory onto human beings. Now, so the question of interest, therefore, is if you are to consider adopting technologies, of course, to address our concerns at the moment, what drives the adoption agenda? Is it industry, or is it science real time that is also creating consumer assurance? Because even addressing food security, one of the components of food security, other than affordability and availability, is safety. So if you don't assure safety, then of course the current burden of disease will tend also to overwhelm our country. As of now, we are still already struggling. So the prevention factors on diet, number one, we are talking about energy balance and exercise. So this is actually now through the help of a nutritionist, you're able to come up with a meal plan suitable to an individual based on his or her anthropometric indices at hand. So you either can be assessed for being overweight or obese. And therefore, if the right education comes in early enough, you're able now to aim towards achieving the desired weight, so that now you minimize obesity and overweight related cancers for that sake. Exercise, of course, that has to help in distressing, of course, our minds. And then, of course, number two, in weight loss or weight maintenance. Fat has also been identified in terms of cutting down on fat, the protein in terms of quality, type, and also how often do we get exposed to. Because see, there are times individuals would go for, say, like a nyam chom session, which means now they only eat nyama alone minus a starch or even a vegetable. Now, the preparation method to that effect. So other preventive factors, we're looking at fiber, which we look into as when it comes to use of fruits and vegetables, and then chemoprevention. There is also an area identified also is on alcohol, so that in this case, recommendations around how much should be consumed for males and females. The question is whether the recommendations are to suit industry needs or for long-term health benefit. Coffee and tea, coffee being a stimulant, of course, also in one way, it also can make you stay long, and therefore, if you're alert for long hours, it means also you're exposed to more food, and therefore likely to eat more, therefore, of course, gain weight. And then, of course, also staying longer minus rest also means you stress your mind. Our bodies become stressed, and therefore, of course, in this case, stress itself also is linked towards promoting inflammation and therefore development of some tumors. Nitrates, and nitrosamines. So this actually, when you look at the debate that was there some time back in the media around some supermarkets using spraying some chemicals to maintain the appearance of the meats under their shelters. So in this case, studies have been done that link the relationship between their use or exposure to onset of some tumors. Artificial sweeteners. So like in this case, this is actually a risk environment, especially now for those individuals or patients who may tend to say resort to using sweeteners other than sugar, especially now for the diabetics or for Weight Watchers, and of course, some sweeteners have also been linked to etiology of cancer. And then method of food preparation, this is linked to what I was talking about fat, because you find that if I was to steam or boil my food, then risk of exposure to aldehydes as derivatives of fat when you heat it will be smaller. But if you are to boil, or if you are to fry, and therefore how often do you fry? And if you are to fry now, assuming you've set your table, how many items listed on the table have you fried? So you may fry everything, therefore meaning you raise the risk bar. You fry only one item, you minimize risk. You boil, you nearly zero on risk. So concerning fruits and veggies, they appear to have protective effect against cancer. And this is thought to be due to the phytoestrogens they are present and phytochemical content of plant-based diets. So the diagram or the picture demonstrates the phytochemicals of interest that have got antioxidative effect from fruits and veggies, which are now therefore being associated with being very essential or ideal in the prevention of cancer as per se. So how does a plant-based diet, for instance, help in the prevention of cancer? So it's by inhibiting hormone-dependent steps in tumor formation and protecting genetic material from carcinogenic agents. It is also suppressing free radical production, as we talked about the antioxidants therein, serving as bulking agents to dilute carcinogens and decrease GI transit time. Because remember, assuming you've consumed a meal or food that has got a higher count of those, let's say, carcinogens, but now on a low fiber diet, it means length of stay in the GI will be prolonged. But now fiber in this case, due to its bulking effect, it means you'll be able to attend long call more frequently, and therefore exposure time is limited. And of course, also one of the markers of how you can actually pick the city's situation in terms of the fiber intake among, like say, the city dwellers. Any best CEO can tell you when you are to find any meatballs, it actually means our habits or dietary habits are actually poor and therefore require attention in terms of people making the right choices towards eliminating the risk of onset of cancers, for example. So they also serve as stimulators of physiologically active and anti-cancer enzymes. So concerning fat, so research, though controversial, has shown that there is some evidence of high fat diets being linked to increased risks for, say, breast cancer, colon cancer, lung, and prostate cancer. So that's why in my highlights earlier on, I mentioned about method of preparation, so that in this case, to be able to achieve the recommendation around moderation being key in how much we take, then of course minimizing use or how much you use in cooking, then we'll actually shrink down the risk of being exposed to some of the tumors. So preserved meats and cancer risk. So some studies linking eating large amounts of preserved meat. So remember, the preservation in this case has to do with the use of nitrosamines or nitrites, which of course now have been linked to issues to do with, like, say, colorectal and even stomach cancers. They may or may not be, no, the onset may be or may not be due to nitrites, because also remember earlier on we said when you look at the profiling of causes, you cannot actually single-handedly isolate the use of, say, red meat as a link. But you see, if there are other core supportive factors, then onset can become real, exclusive of the fact that whether you are not actually being exposed to nitrites. Because somebody will ask, for those who are now, like, say, vegetarians, how do they rank in that area? But you'll find that it's not about now whether vegetarian or now being on meats, but now the thing is what other predisposive factors may tend to risk, rather to increase somebody's risk profile. So nitrites can be converted in the stomach to carcinogenic nitrosamines, which may increase the risk of, say, stomach cancer. Now, concerning the use of, say, nitrites and nitrosamines, the risk of, industry is clever in the sense that you cannot single-handedly isolate exposure to the agent to the disease you're suffering from. So that as in proving causation is the only lame point where now you cannot actually allude because you used a commodity from point X and therefore you have this disease. You can't prove that it was what is actually causing it. That's why striking a balance between how much exposure one has to the risk, and what other modifiable factors can he or she also address so that now you minimize chance. So vegetables and fruits retard the conversion of nitrites to nitrosamine. So basically that's now we are doing the interrelation between, even if yes, you are to have exposure, and then the use of say fruits and veggies with their supportive bulking effect because of fiber and also antioxidants, then you can be able to minimize the consequence of being at risk. So there are some dietary recommendations to effect. One, that is now towards prevention. Eat a variety of healthful foods. So of course, these healthful foods now would come in. Now we talk about having a session or the nutrition education sessions, so that you get to know in my context what could be considered healthful for me. So of course, blanketly we talk about whole grain foods, avoidance of sugar, minimal or no salt, little fat in cooking, adequate hydration, fruits, plenty of fruits and vegetables. But in this case, of course, having a real-time session will actually be able to help you get to know how do I make the adjustments. Adopt a physically active lifestyle. So this is actually to help in also addressing the aspect around energy balance, so that now, of course, if you eat yet you don't spend, then of course you predispose oneself to overweight and obesity, which of course you've identified earlier on as one of the potentiators to onset of some of these cancers. Achieving and maintaining a healthy body weight throughout life. So of course, through what we call now the body mass index, it gives a tentative guide in terms of, if I'm say I'm 1.7 meters, what is my desired weight bracket? So that in this case, by being able to achieve the desired weight, it means you are modifying the modifiables. Because in this case, for instance, you cannot modify genetics unless if there is some form of magic that would come in that direction. So if you can be physically active, eat healthy, maintain a healthy weight, and also limiting consumption of alcoholic beverages or even avoiding them, then of course, you'll actually be doing your part independently towards risk reduction. Now, the plate model illustrated actually can serve as a guide on, like, say, how do we serve our portions in terms of, one, enhancing healthy eating, but also on top of it, enhancing the practice of good dietary practices, for example. So the recommendation blanket is the grains should be whole grain. Now they should form a quarter of your plate. And then the remaining quarter, or rather 1/4 of the remaining portion of that plate should constitute the proteins. Now, the categories here now should be open in terms of whether plant or animal, but the issue of interest is how much and also how often do you use such. And then the remaining half should now constitute the fruits and vegetables, so that now it addresses the benefits earlier outlined on the role they play in the prevention of onset. Now, in the event, for instance, a person now has the cancer, what is the nutritional objective at hand? One is we aim at minimizing tissue wasting and weight loss. So that now in this case, once wasting and weight loss comes in, of course, independently long-term, you'll find that quality of life of that person or individual becomes compromised. So, and this is actually happens by now addressing protein and energy needs through now, like, you come up with a diet plan or a meal plan that helps in addressing the increased needs for protein and energy, so that now you buffer or minimize tissue loss or weight loss cumulatively. And then we also aim at correcting nutritional deficiencies. So of course that will come in now if you have to also consider supplementation or related nutritional prescriptions. Managing treatment-related side effects, but long-term is to improve quality of life. Now, before somebody undergoes the therapy nutritionally, of course, they undergo what we call the nutritional care process, which is a systematic way of conducting assessment to establish the status of this individual in terms of, if we are to look at their BMI, for example, is it ideal? If overweight or obese, then you give education and counseling specific to the problem. Diagnosis. So now you come up with a nutritional diagnosis to address the presenting need. Then you'll actually have an intervention to address the diagnosis established. Then there will be continual monitoring the evaluation, so that now in case there are new changes or emerging challenges, then the patient undergoes also again another set of assessment, diagnosis, intervention. So it's a cycle that is not static, but rather it is all, it is continuous, so that now whenever these challenges arise, they are picked and addressed the earliest. Now, through the process of nutrition care, we aim at identifying, planning for, and meeting nutritional needs. Because we realize that in the event malnutrition was to set in, then long-term implications would be morbidity. So morbidity means now, of course, either progression of disease or other co-infections also set in because of compromised immunity. And therefore, of course, that leads us to number 2, which is about length of hospital stay, which means increased length of stay also means increased burden in terms of workload, but also, of course, long-term, of course, quality of life will also be not be realized. But then, of course, end of life also can be real, that is mortality. But of course, pocket-wise, higher costs. So higher costs, they actually make sense once now you have a real-time contact with patients or individuals who have got these problems. But of course, as healthcare workers, of course, this information concerning morbidity, length of stay, mortality, you are well versed around it. And therefore, of interest is how do we re-engineer care so that now we minimize on the costs, length of stay, mortality, and of course, morbidity. Of course, nutrition care doesn't come in single-handedly. There is medical management and nutrition management. So be it surgery, radiation, chemotherapy, immunotherapy, marrow transplantation, nutritional management in this case comes in to address any emerging challenges out of the treatment being undertaken. So in this case, that is to aim at correcting deficiencies, minimizing weight loss, and this actually will be real if there is timely intervention, promoting oral feeding or using enteral tube feeding or parenteral. So those are the modes of arriving at how do we minimize or correct deficiencies. So it could be either oral, enteral, or parenteral, so that now we maintain quality of life as much as possible. So the diagram or the table highlights, for instance, the calorie and protein provisions for individuals with cancer and individuals without cancer. So for calories for a person who is, like, say, cancer-free, we have a provision of 25 to 30 kilocalories per kg. So assuming that this person, a healthy individual, has the right weight for his height, for example. But in the event the individual succumbs to, not succumbs, but now is, let's say, diagnosed to have cancer, for maintenance purposes, they'll have, like, say, a range of, for maintenance purposes, you assume they will still have the right weight. For maintenance, you'll give them 25 to 35 kilocalories per kg. So you realize there is a 5% calorie increase to cover for dynamics related to treatment pre-existing. But for those who've lost weight, then therefore they require to gain weight for this matter, we have a higher provision of 30 to 40 kilocalories per kg. Now, for individuals who have a healthy weight or who are considered healthy, the provision of protein is, say, 0.8 grams per kg. So assuming I'm 70 kgs, therefore I only need 70 times 0.8, that will be about 56 grams per kg in a day. Now, if you're related to what now mainstream or what is happening near conventional is, 2 or 3 people go for nyama choma and they clear the kg, the 3 of them alone. So that relatively, it means they are doing about 300 grams of protein in that single sitting alone. So remember, this person has not yet gone for his or her lunch, supper, or any of the snacks or tea break at the workplace. So which means, of course, we also tend to, a behavior or practice leads us to, like, end up oversubscribing on the protein or even calorie intake long term. But assuming now you have had the normal weight, but now diagnosed to have cancer, and of course, in this case, having a reason either because of other causes, because remember the causes are myriad, then for maintenance purposes, we'll give you 1.5 grams to 2.5 or rather 1.5 or even higher based on the level of stress. So severely malnourished, higher provisions, but moderately malnourished, relatively or the modest provisions will be given. Now, remember I talked about nutrition coming in to address deficiencies as a result of the various treatment modalities the patients will be undergoing through. So the table highlights the prevalence of side effects in relation to the various modalities.
Well, let's try to get Ngereso back. I think he was experiencing some network issues. Just give us a minute as we try to contact you.
Hello. Hello, guys. Are we there?
Yes, yes, yes.
Hi,
We can hear
yes,
Yeah, sorry,
we
I
can hear.
disconnected due to net issues. So I think we are talking about prevalence of side effects. Fine. So basically, I was saying that irrespective of the form of treatment the patient is on, usually they'll actually experience some side effects, and therefore the role of the nutrition aspect of it is to help in addressing the challenges as they arise by giving custom educational information towards addressing the problem. Okay, fine. Sorry for that. So basically, the table highlights the various forms of side effects that present for whichever form of treatment. And therefore, you can imagine if a patient has both chemotherapy, radiation, surgery, immunotherapy at the same time. So, of course, the broader the risk profile also they'll have towards being predisposed to malnutrition. Yeah, so the diagram simply illustrates a case example of a patient, for instance, who has got mucositis. And therefore, you can imagine now if this person was now to be put on a normal diet, then of course they'll actually experience challenges, one in chewing, and therefore even now in masculating and therefore swallowing. So of course, also depending on the type of food combinations, assuming for instance, you are to allow real-time sugar in such an oral cavity, then of course also you'll actually tend to promote or support the growth of microbes that actually may tend also to exacerbate the mucositis that is already a burden to that particular client. So of course, in this case, other comorbidities will set in, meaning also expanding the role of other pharmacological agents to help in managing or other treating the presenting burden.
I don't know, you or everyone.
Kihugwa.
In cancer, this could come about because of either one, infections and medications that would, for instance, trigger mouth sores, and therefore, independently, that would bring about decreased appetite. But also, even infections and medications, so independently, also they could also dispose one to, say, diarrhea. And that's why, for instance, it would be prudent that we do pharmaceutical stewardship in terms of surveying for what was prescribed and also for how long should the patient remain on. Because at times, if constipation was the presenting problem at the time of treatment, but then now he or she is on a laxative that is not withheld after some time,
they take it as though it's a mainstream long-term prescription, then they'll present with diarrhea, which also may tend to misinterpret. We may tend to misinterpret as healthcare workers as though they have got infective diarrhea, yet it could be, say, drug-associated diarrhea. And of course, we know some antibiotics also independently can predispose one to the diarrhea at hand. So, of course, cumulatively in the cycle of malnutrition, you'll find that if one is too tired to eat, then obviously they'll be operating on a negative energy balance. And assuming if they were to cook on themselves, then they'll be too tired to cook. And therefore, of course, don't expect them now to eat as per what your recommendation can be. So in this case, that's why you'll find that the role of family support comes in handy in addressing the challenge I'm putting across of one being tired, and therefore, of course, even cooking will become a challenge. So if these patients were to present at the clinic, they'll actually tire out quickly and actually prompting even chances of admission. But remember, background-wise, because they have actually been off meals for some time, which is actually provoking the tiredness or lethargy that they present with. But independently also, you'll find that if somebody, for instance, has, say, diarrhea or related, they tend to eat less out of fear that whatever goes into the stomach will come out soon. So, of course, psychological implications will be now the fear to go have loose motions. And therefore, assuming, for instance, you are to travel and therefore you also have diarrhea as a problem, then of course you shy away from food. Now, what will have present long-term, say at the clinical environment, would be they have had constipation for quite some time, but not because, say, maybe because of the disease process, but rather because of the inadequacy of intake that has been long-term. So cumulatively, yes, they lose weight, and therefore, of course, they'll walk by having no strength, or they require the services of a wheelchair or family members to come on board to help them come to the clinic, which also, of course, has got economic implications or socioeconomic implications, because you see, if 2 or 3 people are to come to escort a patient to the clinic, and of course, if the background cause could have just been corrected by having timely nutrition interventions, then we'll actually have people remain in their workplaces, remain productive in the system. Now, there are factors that affect appetite. And this could be nutritional abnormalities, for example, in this case, whereby if there are micronutrient deficiencies, then independently one could be at risk of having reduced appetite. And this now may justify the reuse of appetite stimulants to correct the abnormality. Neurological influences. So neurological influences in this case could come in, for instance, if somebody has, say, a condition that is affecting, say, the brain, and therefore affecting judgment in terms of what the test aversions that may come by, maybe because treatment related or whatever the cause, then appetite will be depressed. Psychiatric, psychological influences, because you see, cancer diagnosis independently also could actually have psychological implications on an individual. So actually, as you look at the diagram being projected, it actually helps each one of us to align ourselves to an area in which how do we come in from that particular loci of ours to be able now to address or optimize on the appetite and therefore increase on food intake. There is intermediary metabolites. So this could be like in the case of impaired glucose tolerance, which now may also push somebody to, like, say, present with hyperglycemia. So in this regard, this can be as a result of the fact that steroid-induced hyperglycemia. Of course, with hyperglycemia, there is actually appetite suppression. So independently also, there will be decreased appetite. And therefore, doing a holistic screening for the potential threats that would actually suppress appetite would be prudent in seeing us counter the appetite implications. So it's upon us now to align ourselves on the diagram and get to see where do I fit in and how do I support a patient presenting with the condition to avert the consequences likely. Now, there are nutritional strategies for weight loss. So those who presented, for instance, with the reduced or weight loss, then the recommendation is we encourage on small but frequent meals. And these meals also should be, they should serve favorite foods, what they like. So of course, through the help of a healthcare giver or family member, then they get to know what would they prefer to take. And therefore, because they may not consume volumes at a sitting, then they're encouraged to spread them across the day so that now to avoid on the miss outs possible. Physical activity to stimulate appetite. These are very important element in the sense that, you see, once sick and therefore you're just bedridden, you connect more to the problem, unlike if you are away from the bed and therefore interacting with the environment around you. So in this case, of course, if you're to eat, even among family members, of course, that independently can connect you to the family, other than if they were so to isolate you, therefore you become physically limited, and therefore, of course, you become nearly even depressed around the condition you are in. Because somebody, this being adults or even the children, they had a life before the diagnosis. So if they connect and they feel there is no disconnect to their former lives, then uptake will be enhanced. Use of medical nutritional shakes and drinks to provide extra calories. So some may have seen various nutritional formulations ideal for various medical conditions. They come in to address the energy or calorie gaps that present, especially when these patients are undergoing aggressive interventions in the management of the problem. So actually this calls for early case referral and teamwork so that we can be able to arrest malnutrition at its earliest stage as possible. So there are pharmacological agents for anorexia cachexia syndrome and weight loss management. So I mentioned about the use of appetite stimulants, metabolic agents, and cytokine blockers for kinetic agents. So that in this case, for those who have, like say, constipation prolonged, once they're able to relieve themselves through long haul, then of course, they'll be able to start consuming or eating normally. Then also the use of anabolic agents. So the table displayed highlights the various interventions for the various presenting problems or challenges in a patient undergoing treatment. So for example, you could have acute gastrointestinal toxicity, nausea, and emesis, nausea and emesis. So the diet now recommendation would be a clear, cold, and acidic liquids, light but low-fat foods. So in this case, of course, as you scan through the table, there are the limitations on what they can use and the recommendations on what is best for such. So this is the kind of education these patients receive to be able to manage the concerns as they arise. So table 2 is just a continuation of the first one, but of course, it still addresses the same issues: the problem, the diet recommendations, any supplemental options to be recommended, and also what to avoid in the event that is happening. However, you realize that there are other commonly used complementary and alternative therapies. So of course, for your reading purposes, you can check through on what people are doing outside there. And therefore, it's also calls upon each one of us to have an independent audit on each of the listed alternatives so that now you can have informed opinions or rather positions when patients raise questions around them. So this is a continuation of the previous one. So there are patients based on the experience or exposure, they'll come with messages around those areas. Therefore, it's upon us as HCPs to be well equipped to address that. Now, an example of interest in the subject is the subject around sugar in cancer. So the question is, does sugar feed cancer? Now, from a PET scan, where now they inject a radioactive glucose into veins, you'll find that the areas of higher metabolic activity will tend to glow. So in this case, of course, the question that arises now is it that now the sugar was facilitating the carcinogenic processes? Now, the next slide highlights the response that yes, though there is a caveat to it. One, all cells in the body use sugar for energy. Now, this includes even cancer cells. And therefore, the sugar of interest here is exposure to processed sugar then means express available glucose for carcinogenic processes. And that's why from the nutrition recommendations, what you are aiming at is cutting down on or elimination of sugar is to nearly help in starving the tumors. So cancer cells are more metabolically active than other cells. So they tend to use more sugar that is. Now, more sugar in this case, you're talking about if the body, assuming like you are to assess from the diabetes perspective, if you consider the normal blood sugar of an individual, say to be maximum 8, and then now he or she has a sugar of above, say 8. So independently, the sugar itself, as it circulates through the vasculature, it is pro-inflammation. Now, inflammation independently is pro-infections. Other than that, also inflammation is a culprit in carcinogenesis. So the extra idle glucose is of concern in terms of where does it serve, or what other functions does it provide other than if you are to limit available accessible glucose, in the body. So the body will make sugar from other sources if you do not get enough through diet. So this actually means, especially by individuals will talk about carbohydrate-free diets. It's not about the carbohydrate because the body requires the carbohydrates, but rather the sugar processed that has express access to tissue, and therefore, because you don't need it urgently, then other metabolic opportunities strike in to make use of it. So the body can break down muscle and fat tissue for glucose, and even the tumor can make its own glucose because also it's a growing cell independently. So in summary, I would say that nutrition is critical in cancer prevention, during care and treatment, but more importantly is early case referral and teamwork is key to optimizing clinical outcomes. Thank you. So in case there are any questions, concerns, the floor is open.
Well, thank you very much, Mr. Ngereso, for that lively presentation. And there are quite a number of questions. I believe some have been addressed. And one of them was being about the issue to do with the sugar. And probably I can start off with one here in terms of, there's one here who is asking in terms of the types of foods and method of preparation still poses risk in cancer. Is baking food or roasting food preferable, and does it reduce the risk?
Well, baking, look at the ingredients in the recipe. So there are two individuals who will bake. One would use whole grain flour, one would use processed flour. So in this regard, the type of ingredients have an independent risk profiling in predisposing one to onset of such risks. So in this case, if I would use, say, whole grain, then it means there is the bulking benefit from the fiber therein or the phytonutrients in the whole grain alternatives. But now doing refined, then it means the ease of release of glucose at cell level upon consumption is, it will be very rapid, meaning inflammation will set in, overweight and obesity will be the risk. So now in this case, you end up now multiplying the risk of factors that would predispose you to the problem. Now, besides that, also in this case, you find that, and also how often does one do the baking? And so it means if you, for instance, you frequently are exposed to that, then it means also the rate of, it's about how often you're exposed to it, and therefore cause effect, as in how long, more exposure, higher risk, minimal, therefore also minimal risk. Any other concern?
Well, there's another concern here in terms of the issue to do with the GMO. There are quite a few concerns here whereby people are asking in terms of, and you need to clarify on, does GMO foods cause cancer?
Now, it's not expressively, you cannot actually expressively associate that the GMO foods cause cancer, but now look at it in terms of the processing aspect of it in terms of from the production. Now, how the environment where you grow these crops will require still the use of, say, herbicides, pesticides for the purpose of maximizing on profits. Not necessarily profit, but rather maximizing output. Now, the risk at hand is if one has exposure to how, I mean, the safety aspect. Safety is in terms of now, how are they handled? How are they handled at the farm level, and therefore at the table, in terms of, they could maybe relatively be safe from the farm, but now at the kitchen now, so you mess up based on how you prepare it. So, and also what is uncertain around the GMO subject is the fact that given that there is some mutational involvement in terms of they clone some bacteria from which is now has been shown to have but it's called the Bacillus thuringiensis, which has been shown to have to confer better benefit in terms of conferring resistance to the animal, I mean to the crop. Of interest is what is the risk to humans. So what the consumers are concerned at this hour is safety. So safety is what the biotechnology environment or the industry has to come in clearly and address. But of course, besides the safety from the professional perspective in biotechnology, it's about also, even if the safety is reassured, how about yourself in terms of your preparation and how often do you expose yourself to such food commodity? Because remember, even the industry is seemingly convinced that there is no problem, because given the fact that
They know you cannot independently single out GMO to be the cause, because remember I said earlier there are other multivariate causes. So what you're aiming at is, we may not actually dispute GMO in entirety, but the assurance on safety from the specialists involved. But even if safety would be assured in paper or in the media, the question is, how about the black market aspect of it? Yes? Next concern. You can unmute yourself and then, let me just go through.
Another question that was posted earlier in terms of the role of ketogenic diet. And then now there's someone else who also asked in terms of what is the role of fasting?
The role of?
Fasting, yeah, in terms of management of cancer.
Hello?
Yes, we can hear you.
Yes.
So there was someone who was asking about the role of fasting in cancer treatment and management. And then now there's someone else who was commenting about the ketogenic diet, use of ketogenic diet in management of cancer patients. Probably you can comment on it.
Now, of interest, now we talk about the role of fasting in management. The problem at hand is that when you starve from food, then the body starts eating your own stores, its own stores. That's why from the PET scan story I was mentioning was that once catabolism starts to set in, when you break down your own tissue, remember, that's where now the wasting begins long term. Now, this is what now is likely to cause now what we would call dyslipidemia, but now that's artificial dyslipidemia because you need glucose instantly, yet now you need to eat it, to get it from your own reserves. So in that regard, it means the buildup of, say, the triglycerides, the LDL, HDL, reduction, and the rest of total cholesterol may eventually now start setting in long term. So in this case, that's why I mentioned about the issue around comorbidities. So that in this case, initially the primary diagnosis may have been, say, cancer, but based on the practice to kind of shy away from the problem, or with the perception of treating the problem, you end up now bringing in other issues with the time in terms of, let's say, dyslipidemia sets in because of catabolism, then of course there'll be now a new diagnosis and therefore a new prescription, therefore even hypertensive setting in. So it opens up now a myriad of new comorbidities long term. So I wouldn't really recommend fasting to be a therapy to that effect. The same is also even related to the ketogenic diet, basically. Yes? Next question.
There was someone else who was asking in terms of, due to the nature of the horticulture industry that we are using, are there food safety policy in place in the country to sort of like address the concerns when it comes to the production of the, let's say, like the bananas and the kales?
Well, in the country, we have got the Biosafety Authority, and actually they've come out broadly, I mean, loudly, this arena around GMO after the approvals. So of course, the laws are there, but of interest is even even now, the matters of food safety, you'll find that in each sector in this country, we have enough laws. Issue is enforcement. Yes?
There's another question here that was asked in terms of, they have noted that most of the cancer patients, especially those with the stage 4 disease, end up being emaciated and wasted. And they are sort of like asking what would be the cause and how can we be able to maintain them in this difficult stage? And do we have the special supplements for them to help them maneuver this period?
Well, at stage 4, it means it actually points to an area around the referral system, because by the time somebody gets to stage 4, it's not that they are coming at the first time. They must have been seeing a healthcare provider from some point or in one area or another. So in this regard of interest that's why I said in my conclusion that early case referral is essential. Now, for those presenting with stage 4, it means these are patients now who will actually require prolonged interventions, so that now you do metabolic rehabilitation. Otherwise, yes, of course, you've got formulations to that effect in managing, but rather they'll actually require enough, I mean, quite a substantial period of time to manage them. But of course, better prevent other than react once in the late stages, for that matter.
Well, another one here is asking about, is there any research on the correlation between cancer and GMO food consumption? Please share some light in this, and especially more so in our country or within the region.
Well, I think it's a good question. Now, the risk of concern on the subject is that, in fact, if somebody was to even look at the background as to why Kenya imposed a ban on the GMO, there was a paper which was done to counter the risks, I mean, to bring to light on the risks related based on the rat model, the laboratory models which were established to demonstrate the causation of GMOs, I mean, leaking cancer in the GMOs. But see, the problem is for every research, there will be counter research. And now the issue of interest is depending on who is stronger in the subject. To mean, if industry has enough muscle to counter what the scientific environment has to put on board, they may speak louder through even the scientists themselves. So in this case, you'll find that it becomes a tug of war other than a focus towards enhancing human lives. So of course, yes, there are papers on the subject, but there are counter papers on the same. So that now in this case, confusion remains to reign over the populations. And that's why, for instance, even you look at tobacco, there is real-time established link around lung cancer and smoking. But you see, of course, you have to look at what the debate is on the subject is that if people know the effects of smoking, yet they still smoke. So why would you now even fight on the GMOs, even if yes, it will be true, there is a link. So for every productive or constructive research, yes, there will always be counter research, but mainly it will be out of bad taste, not necessarily for enhancing the industry for that matter. Because you see, if you have to look at even the history around even the ban and lifting, if you follow the context closely, issues which were raised on why the ban should be there, the question is whether they've now been addressed, let's say as a country, before approval. Yeah, sure. Next.
There's another one here. I think I lumped the two. There's someone who was asking in terms of the use of pressure cooker in cooking. Does it have an effect in the nutritive value of the food? And then there's another one who was asking about can microwave food cause cancer?
The first one was the use of what?
Pressure cooker in cooking
Pressure
the food.
cooker.
Yes, does it have any effect on the nutritive value of the food?
Okay, and of the food, that is, eh? Yeah, it's
Yes.
true. Pressure cookers may tend to, like, you see, there are some nutrients which are heat sensitive or heat labile. So of course, exposing such to superheat in a limited time, of course, destroys those nutrients that are sensitive to heat. For instance, if you were to consider, like, say, iron, then of course now there will be oxidation of the available iron. So the oxide is what now you cannot actually be able to break down at tissue. With your GI, given the change in form of presentation. Now, if you have to look at the microwave, now the microwave story is about the aspect around heat. You see, yes, you can warm your food, but the question is, once you've removed it out of the microwave, there has to be some, it's explained in the manual that you open, even say, the door of the microwave from a side, not while facing or even looking inside the microwave. But the practice to many is they open even looking inside. Yet you need to open while standing aside, so that now if there are any remaining radiations, they can escape through the empty space presenting. But now, if you are even to get that food out of the microwave and then now consume it, yes, as hot. Hot means literally now it means you'll actually end up scalding your oral cavity. So oral cavity scalding now, of course, you see the oral cavity has the cells regenerate too oftenly. So depending on how often you expose it to such trauma, then of course the risk will become enhanced in terms of oral mucositis and therefore even other issues setting in. So it's not about the microwave independent, but now temperature post the microwave, from the microwave. The same is that even now when you talk about hot tea being linked to, say, oral or even esophageal cancers. So it's not about changing the tea independently, but rather, yeah, of course, yes, the chemical components in the tea, the sugar there involved, then top it up now, of course, the temperature, meaning you scald the cavity, the oral cavity. So that's where now you like promote inflammation long-term in the cavity, predisposing now to microbial infestation and a myriad of other cellular changes, and therefore the tumor risk.
Well, there's another one here that is asking, what are the benefits of reducing the sugar in the diet? Then given the reasons given in your penultimate slide about sugar.
Now, if you limit sugar, of course, it's one entry point in, like, say, controlling calorie intake. Because remember, I would go for a second of cup of tea if the milk count is to my taste interest, but also besides that, if I sugar it up, of course, it entertains my taste buds. So progressively, I'll even clear the second cup, not as a single entity, but rather I'll also increase my escort with that 1 cup of tea. So actually, it actually contributes to increased total calorie intake at a sitting. One would say, for instance, what if I only take 1 cup? But you see now, long term, you end up having a bias towards consumption of tea as a convenience, even now for your snacks and even now during your meal times. But on top of it now, remember, it doesn't come in as tea isolated or rather independently. There is an escort attached. So cumulative calorie intake will be higher, unless if you, yes, achieve the desired weight for your age. So of course, now you'll have cut down, or you'll be able to strike a balance between energy intake and expenditure. So cutting down means you reduce on the risk of overweight and obesity, which has got a link to, say, colon or even other related GI cancers. Or in the event, for instance, and also don't look at sugar independently in terms of even cancer, but rather other NCDs, stroke of hypertension, and even diabetes in totality. Yeah, so sugar, what is the goal? Is to improve on taste of food. And therefore, the risk implication repo is better taste, increased portions. Now, if the expenditure is poor and then you store more, and therefore predisposing you, like say, to matters related to NCDs. What is spending? Have I exhausted the question?
There's another one here in terms of, does nutrition play a role in solely basically treating cancers?
Does it play a role in doing what?
Solely, basically treating cancers. In short, they're asking in terms of is it that the treatment for cancer is nutrition?
Not really. Remember, I outlined on the treatment patients will be undergoing for managing cancer. So remember, in the description, there was the aspect around what are the dietary factors involved in the initiation of cancer, promotion of cancer, and also in the prevention of onset, or rather in the prevention or the fighting risk or the chance. So in this regard, you find that the diet changes are necessary at each of the presenting stages. Because remember, we talked about modifying the modifiables, where I talked about if it's about eating other healthy other eating habits, it's upon us to cut down on risk portfolio related to what we eat. Now, in the event now you are diagnosed to have the problem, then of interest is what are the presenting side effects, and therefore how do we manage them as they arise? So independently, you cannot say isolatively, yes, it's the treatment, but rather it has a role in the prevention, it has a role in the management, so that in this regard, we're able to improve on quality of life long term. So it depends on the entry point where one would want to look at it from that angle.
Another one here is about why are some patients being told or being restricted on milk, especially the ones with the CA breasts?
I think it's not actually, well, it depends on source of information, but rather I would say this, that you may restrict milk on the basis of one, if for instance, one has side concerns, like say has got a reflux problem or maybe acidity. So in this regard, what you are aiming, because majority of people when they have say peptic ulcers, it's say in cancer, what they actually perceive to be the solution to the ulcers at hand is when they take milk, it will actually tend to settle the problem. But you realize that at the time when the milk now begins to be digested, the same problem recurs. So actually the restriction, it should be on case basis, not necessarily now for patients with breast cancer, but rather when addressing concerns patients are putting on board, say in matters lactose intolerance, so there is diarrhea, you may now restrict fresh milk, or in the event now if there is gastritis or ulcerative colitis. So these are now other concerns during the treatment of the problem. Yeah, but not necessarily now in the context of say cancer in its entirety. But also remember, in the event, for instance, you are to take say milk independently for him or her who has got also those GI complications, milk is sensitive to bacteria, and therefore, of course, remember with some of these patients, oral hygiene also may be a limitation. So if the milk tends to percolate on the tongue or even in the oral cavity, then it actually becomes a breeding ground for also microbial attacks, and therefore proliferating the problems presenting. But to be on the point is the fact that one should be case specific. What is the concern the patient is presenting with, and therefore the limitation. If there is diarrhea, then limit dairy. So that now, of course, you arrest risks of, say, lactose intolerance or any other. If there is, say, somebody has an allergy to some form of protein, which could be animal-based, then of course that will be justified, but not necessarily in breast cancer.
Well, we seem to be having quite a lot of questions here. There's one which was asking, what are the best foods or fruits to give when they are constipated or they're having poor appetite?
Well, there is no single bullet in the choice of fruits for that concern, but rather you see appetite as when you look at the diagram I'd shown earlier. If, for instance, assuming you're not even a patient and then you are psychologically disturbed, the body's priority will change. So food will not be the emergency at hand unless you've arrested the background problem at hand. So in this regard, of course, single-handedly now linking to a single fruit to be a bullet, that may not be, response ideal for the burden at hand. So what I would recommend is psychologically, of course, through physical activity, you may end up distressing your mind. So once you are alert, therefore now you settle, disconnect from your issues or problems, then of course you'll actually have the peace to enjoy your meal. But of course, in this regard, variety is the emphasis. As in, nature provides different options. So as they come by season or based on what is access to where you are in your local environment, then use different alternatives, but also have people or family support around you. So now it's a lively environment, because you can imagine if somebody, one is tired, not even as a patient, but now you walked home, you are tired, and then you're the person also who is supposed to cook. So of course, and then after cooking, you're the person also to do the other, the washing. So it's cheaper to withdraw from those activities in the name of I'm tired, but not because you don't have appetite. Yeah, so variety is the message. Okay.
Oh, okay, now there's another one here which was asking in terms of what is the alkali diet and what is the benefit of the same in the prevention and management of cancer?
Alkaline diets, of course, of interest in them is basically is trying to create an environment or situation whereby the pH of the body is towards near neutral. Because you see, what may tend to promote inflammation is basically when the pH is low, as in anything say below 4 onwards, or even anything below say 5 downwards. So in this case, you find that when there is a increased, rather a drop in the pH, meaning now the body has become nearly, I would say, acidic, then of course it's a potentiator for inflammation. And therefore with inflammation, then the body will actually, through its defense mechanisms, see an increase in the production of cytokines and the rest of such to counter the presenting threat. So, and of course, physiologically also you're trying to fight the inflammation, but also now creating new tissue to recapitulate the areas of that have been affected. So alkaline diets in this case, basically they're aiming towards one, dropping the pH towards anything above 530. So that now it's near neutral. Of course, it can't be neutral because there has to be a balance in that area. But in this case, what you want is the body, the serum or circulation fluids should not be as acidic if you are to do as per normal pH level or the ranges. Now, so this includes mainly now, like say, hydration is one way of also now, diluting on the pH to make it towards near alkaline. So that's why if you aim at towards 6 to 8 glasses, not at a sitting you take the 2 liters or the 8 glasses, but rather spread them across the day by sipping along the day, not by gulping. Because you gulp now, you actually flush it the soonest. And then now cutting down on acid formers. So acid formers mainly now will be the meats, because you see now once you catabolize the proteins, especially now from the meats, now there'll be the issues around now amino acids. So depending now on how much, how often, cooking method. So you see now if also you are to fry it, the acid levels also will actually tend to be now super frying. That is more fat also means increased production of weak carbonic acid, sulfuric acid, and the rest of it. So meaning cumulatively, the body becomes near acidic. So alkalining the body may require now hydration, and then now cutting down on the meats, cutting down on the sugar, cutting down on or even avoiding on fat, sugar, and also now hydrating. And then of course the adoption of plants and rather not plants but rather fruits and vegetables for that purpose. And that's why in some communities, like say in Kenya, you find now they roast some peelings for banana peelings, they boil it, and not boil it, but rather they roast it when they are dry. Of course, it's in one way of tenderizing, which means it's a base, and therefore helps in diluting pH. So plants and fruits and veggies come in handy in the alkalizing process.
Well, probably because of time, I think we're just going to have this last one in terms of someone is asking, so therefore, should we encourage the preservation of the traditional way of preservation of meat and the refrigeration as opposed to, because now you said it leads to CS stomach.
Now, what I would recommend is the fact that the natural way of preservation, you see, they would do smoking, but you see, even now smoking itself also has got some components of pro-carcinogenesis, because you see, once you roast the outer, once the outer proteins on the beef are scalded, imetengeneza ile jivu, Of course, that is a breeding ground for aldehydes. Aldehydes now have been the culprits towards being pro-carcinogenesis. But rather, what I would say, other than preserving, you see, refrigerators came in for the purpose of, in the event you are not in an environment where you can have steady supply. So, for instance, now I'm in Lodwar. Then, of course, I may not have fresh supply of chicken, which means, and also it is short-lived. But you see now, what many of us have done is we even preserve, yet we have access next door to like say to a butcherman who will actually give us fresh produce. So of interest to us should be aim to have fresh produce more regularly, because even if now even you have to preserve also the longer you keep the fruits or even whatever the vegetables, the nutritional profile deteriorates over time. So eventually you end up taking in now more roughage, but devoid of the macronutrients of interest. So if best or the possible, have regular access to fresh supply other than prolonged storages, which other than now the nutritional deterioration with the time, of course, it also prompts you now so even to consider adopting techniques to keep it longer so that now you can use it over a longer period of time. Of course, for economics, it makes sense that you buy in bulk, it is cheaper, but remember, you cannot trade your health long-term for today's convenience.
Well, thank you very much, Mr. Ngereso, for that presentation on nutrition in cancer. I know most of the things you've shed light on, some might bring up more questions, of which I believe we've been enlightened a bit. And with this, I'd want to hand it over to the host so that now they can be able to discuss the issue about the CPD, because I've also seen it was partly some of the issues which are being raised. So thank you very much for attending the session, and have a lovely afternoon. So back to you, Charles.
Thank you so much. Mine is just to thank the participants for joining us today, and our speaker, Kihugwa, and moderator. Thank you so much for the wealth of information that you've shared. I'd like to hand over to Nelson to address the issue of CPD.